Hello, everyone. Good afternoon, good morning, good evening, as the case may be. I'm really happy to be part of this session on task shifting in community mental health in India. At the outset, I'd like to thank the organizers of this wonderful workshop. I'd like to thank Nicole and Michaela for inviting us to do this session. I'd also like to thank Professor Guzder. It has been an honor to be working with the McGill team on this wonderful workshop on community-based mental health. And we are really happy to have an opportunity to talk about our experiences from the field, engaging with the question of task shifting in community mental health in India. So to introduce myself, I'm Shubha. I teach in the Indian Institute of Technology in Hyderabad, and I'm joined by my colleague Sudarshan Kottai, and we will be speaking about our experiences with task shifting in community mental health in India. And what we hope to do in this session is to raise certain important questions about how do we understand health, mental health, community, participation, and a number of other buzzwords which have become really prominent in the discourse on community mental health. So, at the beginning, I'd like to start out by laying a little bit of the background in terms of the different contexts which have influenced and shaped our work. Firstly, in terms of the researcher context, both of us, Sudarshan and myself, we are trained psychologists who have been stepping outside the disciplinary boundaries to look at questions of mental health, distress, and healing. We have drawn on anthropology, medical anthropology, and sociology. We have used extensively anthropological approaches such as ethnography in paying attention to the different kinds of contexts which have shaped people's experiences on the ground. And this is where I come to the field contexts which have shaped our work. Our work is grounded and located in a different context, different field sites in India. So I will be talking about a few cases from Western India, and Sudarshan will be talking about his experience in working with Southern India. But what we also understand is the context of India is also influenced by certain global movements and global events which have really shaped the field of community mental health. And this is where I'd like to pause and take a little bit of time to outline some of the broader developments in global mental health, which have actually influenced how community mental health operates on the ground. So, we are familiar with the global mental health discourse, which has largely argued that there are alarmingly high rates of mental illnesses which are untreated across the world, but particularly in low and middle income countries. And the global mental health discourse, which has been discussed and debated over the last 2 decades in a number of journal articles, conferences, workshops, and so on. The global mental health discourse speaks about a treatment gap between people who are in need of services and those who actually receive care and services. And the assumption here is that there is an imperative need to scale up mental health services through the use of different kinds of approaches. So, one of the approaches which has been advocated is the use of primary health services in order to provide mental health services at the primary site itself, particularly given that in low income contexts, quite often the primary health network is actually really important in providing a range of services for populations. Given the kind of wide reach of primary health services, given the shortage of specialists, such as psychiatrists, to actually deliver mental health care, the argument has been for pushing for mental health through primary health services. Another approach which has been advocated is the use of community resources. And these community resources could be institutions, they could be community based organizations, they could be NGOs, they could also be healing shrines and religious institutions, as I will be talking about. So, integrating community mental health with these existing institutions has been one approach which has been advocated. But the global mental health movement also has seen a number of critics, and without going into too much of detail, just to sort of give a backdrop, one of the fundamental critiques has been the cultural critique that the global mental health movement often doesn't pay attention to local realities, local contexts, lived experiences. And this is where we hope that our experiences and observations in the field can help to actually unfold and unpack what community mental health really looks like in specific contexts. The other kind of critique which has been espoused by a number of scholars has been the political critique that global mental health really amounts to a different form of colonization. And what is really required is more voices from the global south, outlining their own needs and concerns without necessarily submitting to a homogenized and medicalized kinds of paradigm of mental health. Um, and finally, we have important critical voices from user survivor and disability rights movements who have argued that it is imperative that the users of mental health services, the survivors of mental health services, have a say in the kinds of programs and interventions which influence them. So, this is a broad sort of context within which community mental health actually takes place in the Indian context. In the Indian context, one can see a dominance of a very strong kind of medicalized approach to mental health more generally. Um, and this is also accentuated by the global mental health movement. When it comes to the question of religious healing, because my own work interfaces between religious healing, religious sites, and mental health, we can see that there is a long standing interest in healing shrines in the field of medical anthropology, transcultural psychiatry, much of which has documented that in a variety of global south contexts, including South Asia, including India, the landscape within which service delivery operates is a landscape of medical pluralism. And this medical pluralism has been studied by a range of different kinds of scholars, some of whom have argued that what is really important is to try and see if religious sites of healing can be used as a base for providing mental health services. And this is where some scholars have talked about the need for collaboration between biomedical psychiatry and traditional healing. And yet, others have also cautioned, and my own work also suggests this, that any such collaborations need to be approached with caution because of the very different kinds of power differentials and dynamics which operate between biomedical psychiatry and traditional healing. So, this is the context within which mental health sort of operates in the Indian context. And task shifting has come to be a very important endeavor here. Task shifting is something which is emphasized both in global discourses of mental health as well as in Indian national policies around mental health, whether it is a national mental health policy or whether it is the Mental Health Act, where essentially the argument has been that given the shortage of mental health professionals in low income contexts like India, there is a need for providing access to mental health services through a range of other kinds of professionals who may be paraprofessionals, who may be lay persons, but who are providing mental health care. And through the use of all of these very different cadre of staffs, one can attempt to scale up services and bridge the treatment gap to basically move towards providing mental health care for all. So it is in this direction, it is with this intention that a number of NGOs have also come up to focus on providing mental health care to communities and increasing access to biomedical treatment through task shifting by training an array of community based lay health workers. But as we will show in our work, there are certain challenges, there are certain concerns when engaging in such kind of task shifting. So what does task shifting really mean in actual practice? That is what we hope to illustrate in our work. So I'd like to lay out certain overarching questions through which we would like to approach this session. And we hope that over the course of the workshop, over the course of this session, you can also mull over these questions and then reflect on your own engagement and your own work with the different communities that you are engaged with. So the first is a question around the issue of care. And this is really a question about what do we even understand or mean by care? What happens when care becomes translated into mental health care? When care becomes framed as an issue of mental health, how does that really change the kinds of dynamics? What happens when support becomes framed as peer support? Again, here the language of mental health, the language of global discourses of mental health which are used become extremely important, because quite often what we see in South Asian contexts, including in India, is the appropriation of the language of global mental health, even though the context in which they operate might actually be quite different and quite variant, right? The other kind of question that we would want to leave you with is questions around community and participation. And what do we really mean by participation? Whose participation are we really seeking to involve, and whose participation becomes disallowed? Do community mental health practices really engage the community? What do we really mean even by community? And how is that different? As my own work will illustrate, quite often the idea of a community is really a very diffuse kinds of notion. And it doesn't really imply the kinds of solidarity that we typically associate with the term community. And finally, we hope to illustrate in this session and raise certain questions about mental health and well being in general, such as what are the kinds of political implications of the framing of distress into mental health issues? What happens when diffuse, ambiguous, ambivalent kind of distress gets framed as a mental health issue? What is lost in the process and what is gained in the process? So we hope to sort of, raise some of these questions during the brief amount of time that we have with you. We will be outlining two different cases from two different sites of community mental health in India. I will be speaking about a community mental health clinic located within a healing shrine in Western India. And my colleague Sudarshan will be talking about community based mental health services in Kerala linked with the already existing pain and palliative care system in that context. So let me take you now to Western India, Gujarat, where I will be presenting briefly a few snapshots from the field based on my own research in a community mental health clinic, which is affiliated with a religious shrine. So this is Gujarat in Western India. And there have been, when we look at the research on religion and mental health in India, we find that there is a range of research and resources uh, which have examined the medically pluralistic kinds of landscape in the Indian context, where care is provided through a range of different kinds of practitioners, including biomedicine, including religious healing, as well as Indian systems of medicine as well. But the immediate context also for the operation of and the establishment of the clinic in question is sorry, is the Eravadi incident, which occurred when there was a fire in a private home around surrounding a religious shrine, which was a Sufi shrine in South India in Eravadi in Thiruvananthapuram, and this was um, this was a fire which led to the death of several persons who had been chained to their beds and therefore could not escape the fire. And this became an important sort of event which actually raised considerable kinds of public outrage, as could be imagined. A number of events sort of took place after the Eravadi incident, as it has been, referred to, and essentially religious shrines or healing shrines, which have a long history, a long tradition of providing shelter to persons who are, in other words, homeless or who have chosen to leave their homes or who have been abandoned at religious shrines. These religious shrines suddenly now came under the scrutiny of the state. So, following the Eravadi fire and the death of the around 27 or so inmates who had been tied to their beds and they could not escape, following this incident, which was highlighted in the public media, a number of events took place. Um, the the Indian state's response was to shut down a number of private asylums and then engage in a systematic process of monitoring healing shrines and uh, seeking to close down several healing shrines and instead direct persons to sites of biomedical psychiatry. So in a number of sites, for instance, these shrines were closed down and persons were instead transferred or sent to the closest mental hospital, right? And yet there were concerns about the state of functioning in mental hospitals itself, where again there was a lot of focus on the kinds of human rights violations which take place there as well, and often the lack of services and care which is provided. So there was also a considerable amount of media coverage on mental health issues. We began to see a number of different kinds of programs aired in the national television, speaking about the need to pay attention to mental health. This is just one example of some of the some of the programs which were aired on national television, talking about the need to pay attention to mental health. So suddenly, mental health now became a national issue. It became a question of a question of concern for the general public, right? And it also became a question of development, as you can see in the quote above by the famous psychiatrist, who says that when you suffer from depression, you don't find any difference between Switzerland and the slums. You hate even the smallest of noise, and you want to be left alone most of the time. Um, and what also became important is increasingly mental health began to be framed as in the language of biomedical psychiatry. So what I want to talk about in the little amount of time which I have is research which I have done over the past a few years in a particular site in Gujarat, which is the Mera Datar Dargah, where I have been carrying out participant observation and interviewing persons seeking care, as well as carrying out interviews with healers in the shrines and mental health practitioners as well. And um, through this research, what I hope to demonstrate is that quite often community mental health um, operates in very different ways in actual lived context. So this is Gujarat, the site where I had done, field work in Western India, and this is located in, Western India, and the red circle on the right is the site, the district where the shrine is located, where I had done field work, located about 100 odd kilometers north of the capital of Gujarat, Gandhinagar. This is the site when I had visited there several years ago. Now, what is important in this healing shrine is that clinical interactions in the healing shrine are actually shaped quite like the kinds of clinical interactions which one observes even in any kind of biomedical psychiatry unit, any kind of outpatient clinic, right? So there is a very strong dominance of the medical model of psychiatric treatment, as will be evident in a few cases that I will present. Um, Essentially, this was a site which prided itself at as being an exemplar of collaboration between biomedical psychiatry and religious healing, because the endeavor was to provide modern medical treatment within a religious site, within a site located within the community and close to the lived experiences of individuals. And yet, what one observes in actual practice was that in many ways, the clinic actually functioned quite like any other outpatient psychiatric clinic. So the clinic was initially established within the space of the dargah and then later moved on to establish itself outside but just adjacent to the shrine. And pilgrims who were visiting the shrine were essentially told that in addition to the prayers and the kinds of rituals that they were engaging in at the shrine, they could also benefit from consulting the psychiatrist who was offering services at the clinic. And this was a program which was funded by the state and run through an NGO which was actually operating the everyday kinds of operations and administration. So pilgrims who had decided to come from all parts of India to the shrine because they perceive themselves of in need of some kind of healing, they perceive themselves as having some kind of distress, they were often directed to the shrine, and they were often directed to the clinic, sorry, and they consulted the psychiatrist there, and medicines were distributed to them, were handed out to them at the clinic itself. So medication management became one of the main focuses of the treatment in this kind of community mental health practice. And there was a considerable emphasis on adherence to treatment. And essentially, what one observed was that the shrine became a base and was really used by the clinic to gain access to a large number of individuals in order to disperse biopsychiatric medications, right? And so, what does community mental health mean in this kinds of context? And others like Sumit Jain and Shishlo Jadhav have talked about how, in a number of contexts, what community mental health really means is it becomes reduced to an administrative exercise of medicine distribution, right? Where care becomes translated into treatment, and a certain kind of treatment, which is largely medication kind of treatment. So I want to illustrate this by presenting two cases from this particular clinic, just to give you a sense of the nature of consultations in the clinic between the psychiatrist and the consulting pilgrims. So this is a case of a woman who I call Geeta, who presented at the clinic with the primary problem of headaches, right? And this is a transcript of the exact conversation between the psychiatrist and Geeta. As you can see, the psychiatrist asks a range of questions to Geeta about the nature of the symptoms and how long she's been having them. There is a question, do you have thoughts or worries? And then when Geeta responds, yes, I have worries, and then she sort of leaves off. Again, a range of questions the psychiatrist asks. Do you feel sad? What do you feel sad about? Do you have tension? And following this very brief conversation, the psychiatrist immediately gives a diagnosis of migraine and major depressive disorder, and Geeta is put on an anti-migraine drug and an antidepressant drug, right? Now, largely, patients are tend to be maintained on the kinds of medications that they are put in. So while medicines are initially distributed to them for about 2 weeks or so, or at the most 1 month, they return after that duration to pick up the follow-up kinds of medications. So this is another case of a woman who I call Abida, who also complained about headaches and pain, where the psychiatrist asked her, what is the problem? She said, my head hurts. And then he asked her, where does it hurt the most? There are a series of questions about the nature of the headache and the pain. And what is also evident is that Abida was sort of dramatically responding in the affirmative to most of the questions which were asked to her. So, for instance, when he asked her, "Do you have any memory problems?" then she sort of, dramatically responded, "I sometimes I don't even remember what I ate in the morning. Sometimes I can't even remember in my name." Right? Um, Following this brief conversation, which is reproduced in full here, Abida was given a diagnosis of somatization and cluster headaches, and she was put on antidepressants. Now, one of the trends and one of the patterns which was frequently observed here in this clinic is the tendency to categorize headaches and pain as somatization, right? Drawing on a logic, a mental health logic that uh, quite often people's pain, people's somatic symptoms were actually indicative of deeper psychological sorts of issues and distress. And so again, Abida was put on antidepressants without really delving further into the other kinds of symptoms that she might be facing or the other kinds of issues that she might be facing. So it was quite often that such kinds of complaints of non-specific pain were categorized as somatization, which is also something which is frequently seen in a number of cases where task shifting is employed, where lay persons are sort of, carrying out mental health service delivery. And when I interviewed the psychiatrist about this, he he responded by saying that she is a middle-aged woman from the minority community, and they usually show somatization at this age. We see several women from this community present themselves with the same symptoms. Half of these patients have depression. And he also opined that even if she did not really have depression, or her headaches might be due to any other conditions such as anemia, she would still benefit from mild antidepressant medication. So the assumption there being put on psychiatric medication could not be harmful in any case, even though there were instances and there were cases where people were suffering from serious kinds of side effects due to having been put on medications for really long durations of time. I'm going to skip this case in the interest of time and move on to talking about, what do these two brief cases, which I have highlighted, really say about how community mental health operates in the ground, particularly when often such mental health care is task shifted. In this case, it is an NGO which is, running the mental health clinic. There are a range of counselors who are employed to actually carry out work related to awareness building and sensitization. But essentially, what also transpires here is that mental health care becomes reduced to the provision of psychiatric medication. And these psychiatric medications carried an important kind of material and symbolic value for different kinds of actors who were involved with them. For the state, it symbolized that the state was actually doing something concrete by actually providing some kind of care, some kind of care in the post Erewadi context, where there was quite a bit of national outrage about the dismal state of affairs relating to mental health. For the mental hospital administrators, the clinic was also very important because this was a site which them provided them access to a large numbers of persons, a large population who they presumed were in need of mental health care. And so, quite often, what community really means in many contexts is simply the availability of large number of persons, simply large populations, rather than any imagination of community as having any kinds of solidarity or networks. And for the healers in the shrine, the clinic also became very important because it symbolized the willingness of the shrine to modernize itself, and it also symbolized the importance of the shrine in providing also medical care and medical treatment, and thus raise the status of the shrine. So while there are disturbing questions about the increasing amount of psychiatrization of distress and medicalization, whereby even diffuse kinds of symptoms such as headaches are instantly categorized as depression or anxiety disorders without sufficient kinds of exploration. What we also see is that for many different kinds of actors, this clinic was actually serving some kind of need in some way or the other. But at the same time, the observations of persons being put on psychiatric medications for a long period of time, for several months, as I had observed, and then eventually also suffering from side effects due to the excessive amounts of psychotropic medication. So these also raise questions about the kinds of chronic conditions of living that we are really fostering, and what are the new kinds of subjectivities which are actually being created in the process. Quite often pilgrims were also eager to obtain the medications, as the provision of free medications also gave them a sense of being a citizen and having access to some kind of benefit from the state. So when mental health interventions are framed or are couched as development initiatives, then there are also concerns about the kinds of power differentials which are operating. Janice Jenkins has talked about, the pharmaceutical self, right? And others like Susan Reynolds White and others have talked about the social efficacy which medicines carry. Quite often, medicines become really powerful, not just materially but also symbolically, because they actually symbolize um, that one is receiving some kind of concrete benefit or concrete treatment or care from the state. And for individuals who are in marginalized positions, receiving this kind of benefit is in itself important in basically placing their citizenship. So, what I hope to do through this session is to raise questions about the kinds of challenges in community mental health, particularly questions about what do we really understand when we talk about things like community, things like participation, and even mental health. So I'll stop here at this point and invite my colleague Sudarshan to come and present his perspectives and experiences of working on community mental health in Kerala. Thank you very much.
Thank you, ma'am, for the presentation. I will upload the PPT. Hope this PPT is visible.
Not yet.
It will take some. I think it's common. I have to find. PPT will be uploaded in a few minutes. I think there is an issue. I will just start off. So what I will be doing is that I will be presenting some of my experiences and some cases that I have observed during my fieldwork in the state of Kerala, which is in South India. So these mental health programs, community mental health programs, are actually run by uh, NGOs in partnership with the pain and palliative clinics, which are already existing in the state. Uh, also in partnership with other funding agencies. So as you have already know about community mental health programs in India, the Kerala example is something which is similar as similar in the way in which it is being practiced, but slightly different also because there are certain organizations such as the pain and palliative clinics which are already existing with their own infrastructures and which are potential sites for some NGOs to partner so that they act as a conduit through which they can offer services. I'm very sorry for this delay in the presentation. I will try to manage within the time frame. So I will start. So contextualizing mental health in India, we have seen, we all know that India is a low middle income country, and the global governments in mental health have been asking for or calling for increasing access to mental health services in the global south. So, India, in particular, some data that I have just shown in order to contextualize what it means to be mental health in India. So it has consistently fared very low in certain global indicators of social health indicators. So like global hunger index, you can see stunting and wasting, which is very high in the country, and in gender discrimination uh, uh, by gender index, we can see that it falls in the very poor category. And end of childhood index also, like people, children are facing very bad situations like malnutrition, exclusion, child marriage, child labor, etc. So these socio-political and economic realities make the understanding or create different perspectives about how to intervene in mental health from various scholars. So many of them have actually have talked about the need to look at the social determinants or structural determinants of mental health, particularly when there is a lot of isms like casteism, classism, and sexism, all this which are very prominent in the Indian heterogeneous society, and also the coloniality that is already there. And people have been talking about the need to decolonize mental health also. So just briefly about some of the recent incidents which raised more questions about what kind of mental health, what it means to be mental health care. So the migrant workers crisis that happened during the pandemic was criticized by many activists as well as other scholars, saying that the global nature of the interventions were mostly imported. So it was just a mental health response to migrant workers who faced a lot of state-sponsored, I mean sponsored apathy and state-sponsored uh, 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 the violence that were inflicted onto them. Like many people have died without food, water, and transport. And farmers' protests also, because most of the mental health programs and mental health research in India, mainstream mental health research, have focused on farmer suicide, looking at it as just a medical problem. But when the protests happened, are happening even now, farmers' protests, and many other farmers have also committed suicide. But there has been no there is no mention or no concern about those suicides, and there has been no position statements or editorials which were written in the psychiatric journals or as such, which is seen which was not seen. And other like the farmers' protests and migrant workers' crisis suggest, most of the other social pathologies like poverty and other social structural violence are mostly erased out of the mental health scene, and most of the distress which happens due to all these factors are simply reduced as a mental health problem and treated with medicines. That is one of the major criticism which is raised against the community mental health program also. So community mental health program, as I have seen, is that it is just an import of the already existing biomedically oriented mental health services that happen even in a just like in a tertiary mental health center, maybe a medical college hospital. So this task shifting again raises important questions because in the face of such complex social realities in the country, how task shifting in the low resource country like India with lack of mental health professional, how this can be employed. So briefly about Kerala, Kerala is an outlier in the whole of the South Asia with regard to many social other and health indicators. And politically, it is also well known because it is the first government. It had the first government, which is a communist government, which was voted to power democratically in the world. So, a lot of investment in health education that even Amartya Sen calls it as an a capabilities model. So that has actually helped Kerala emerge as one of the high-ranking HDI in the country, high HDI ranking state in the country. And with respect to literacy rate, also it is the top state, and digital literacy also because of the presence of the internet access to internet that has also helped in reaching the uh, top position, and newspaper reach also because of literacy. These are all interrelated. So also government of Kerala has been also in the forefront of actually taking care of some marginalized sections like migrant workers, which is not seen in any other state, like insurance, and also during the COVID-19 crisis, it was actually a very caring approach where nobody had to walk or nobody had to sit hungry. And at the same time, Kerala is also the state which is said to be having the mental health programs spread across all the districts. Other in the DM district mental health program, which is which is being the community mental health program, which is run in all the districts of the state. So my research was actually done in a pain and palliative care in community mental health programs, which are essentially pain and palliative clinics, which collaborates with mental health NGOs to offer mental health services. So pain and palliative care movement is also one of the major uh, uh, health as well as a social movement that happened in the 1990s in Kerala due to the particular socio-political context that is present in certain pocket in certain areas of the state. So this pain and palliative care centers are now sites for mental health programs also because they have expanded their reach to not only the bedridden and the chronically physically ill people, also to take into consideration the suffering of mentally ill people. That is how they also ventured into the territory of mental health. So in order to uh, fulfill this, the mental health NGOs have also come up. So they found these sites as potentially useful because they have already volunteers are there already who are working in the area of physical health, like bedridden people, paraplegia, quadriplegia, tuberculosis, other physically ill. So already community volunteers are there, infrastructure is there, ambulance is there, buildings are there. So they just use this and they collaborate with the and they train the volunteers in mental health. So the mental health NGOs have certain criteria to induct patients in this mental health program. Basically, they see that they make sure that they are severely ill, they are chronically ill, and they are also come from the low socioeconomic background. Because of the spread of pain and palliative care center, the number of community psychiatric OPDs have also risen because the the pain and palliative care centers have been collaborating with mental health NGOs, and mental health NGOs are also interested in actually creating such spaces with pain palliative care centers. So task shifting becomes the main driver in these community mental health program because the NGO has very few mental health professionals, one psychiatrist in one NGO, and in the other NGO also mainly one psychiatrist. So they are not able to service the whole mental health OPDs which are which have opened in the pain and palliative centers spread across many, it's around 5 districts, which I have actually seen. So this ethnographic fieldwork, which I have done for 11 months in the 2 NGOs and one government organization in Kerala. So this talk is based on that fieldwork. So this is a vehicle of mental health, an NGO which used to go to 2 clinics in the morning as well as in the evening to the pain and palliative clinics to offer mental health services. So methods I have used in-depth interviews, I have done home visits and also done participant observation and analyzed case record which are kept in the clinic as well as with the patients in analyzing the data. So this photo is of 2 ASHA workers who are ground level health workers in India who are 10th, who are secondary school pass women who are inducted in the health system to network with the local community. So they are trained, they were trained by the NGOs to offer mental health services, basically to identify and diagnose mental illness uh, in those pockets in the urban areas in Kochi Corporation where there is no access to mental health services, and to refer them to the public health center with which the NGO is collaborating to offer mental health services. So these NGOs are also collaborating with government PHCs as well as pain and palliative care centers also. This slide just shows the summary of my fieldwork data. After that training happens only for 2 days for the ASHA workers. One day I attended one of those training sessions on one single day that happened from around 9:30 to 2 o'clock. And that training session mostly discussed was by a psychiatrist, the director of the NGO, who brought in PPT and was talking about the symptoms and the main diagnosis that of psychiatry like schizophrenia, depression, anxiety, etc. And it was a talk which is directly imported from the mainstream psychiatric textbook, which shows what are symptoms and how to identify those symptoms and how to diagnose. So after this training, the social workers are supposed to handhold the ASHA workers for identifying the people in the community. So I actually went along with them, with the social workers as well as the ASHA workers. So this incident is happened the next day after training. So the ASHA workers and the social workers went to a home, door-to-door visit. So there was a woman who was present. So she was aged almost 60 years. So the social workers said that she has to continue the medicine which she was taking because it was mostly the sleep medicine that she was actually taking earlier. So the ASHA workers are also now trying to look through the lens of psychiatry in identifying diagnosis. So they had a checklist also like OCD, what it means, and there's a checklist to fill up. So they ask like, do you see anything, like to check hallucination, delusion, all this. Main symptoms, are you feeling low? So she was just asking about whether she was suspecting OCD. So she asked whether you are extremely clean. So she said that it was nothing like that. I have tension and she cannot sleep without medicine. So because, and also the reason why is that uh, her brother and sister both are bedridden due to stroke, and because she is because whenever she see them, she gets tensed. So she said that she was okay earlier and was just very smart, but she is now having tension. And whenever she see them, the brother and sister, she feels upset and cry. So social worker tells the woman that you need to continue the medicines and consult the doctor once more. There is a new facility which has opened near the her home, that is the PHC. So medicines are taken to prevent the recurrence of mental illness. The social worker also tells the Asha once we left the home, when we are going to the next door, next home. So on the way, she was also, because she's hand holding for a week. So she said that not only this, you need to also educate the people that it's a brain disease and it should be cured with medicine. So what I found is that this kind of a biomedical understanding about mental illness is transferred from the psychiatrist to the social workers who are non-medical mental health professionals who are first postgraduates mostly, and this is again now transmitted to the local volunteers, that is ASHA workers, who are uh, part of the network, that the ground network in healthcare. So also something that I have found is that because of the task shifting which is mandated, because it is imperative also, the psychiatrist is coming to the clinic. That has become very infrequent over the years. 2015 when I started, and 2017 there were like 1 year, more than 1 year gap, where the psychiatrist or even a general physician has not seen the patients. And the in the absence of the psychiatrist or a medical professional, the psychologists and social workers or clinical psychologists or the psychiatrist social worker just prescribe medicines on behalf of the psychiatrist, and this is done through telepsychiatry and telephone psychiatry, that I call, because initially there were some attempts to actually contact the doctor over the Skype or over the phone, but most of the times the psychiatrist was found to be busy or they are not able to contact, due to which the even when there was severe side effects and other complications, they used to try to contact the psychiatrist, but they were not at times not available, and they used to write, repeat. And so because of this, there has been a lot of side effect due to polypharmacy and other complications. So these examples show, these narratives show the problems faced by the users of these community mental health program due to unmonitored polypharmacy and related complications. So when I visited other mental health clinics and also talking to the caregivers and other people around in government settings also, I found that many of them have got admitted to tertiary mental health facilities and tertiary hospitals like medical college hospitals, when these side effects prove to be very fatal and very complicated complications due to complicated side effects. So this is another uh, incident which happened, where I was actually sitting in a community mental health clinic, and with me was the clinic was that day the clinic was managed by a psychiatric social worker. So she was acting as a psychiatrist, because of all these psychiatrists, psychologists, and social workers are uh, act like psychiatrists, because they don't reveal their identity even when the patients or the users or the caregivers address them as doctors, because it gains lot of prestige and lot of authority, and that kind of a respect also, it commands the respect also. So they don't reveal this. There is a lot of identity crisis also, because how they negotiate their real identity and their concealed identity. So most of the of the caregivers, the local people, or because most of them are coming from very low background, so maybe some of them are illiterate and don't know the nitty gritties of medical profession or this psychology, psychiatry degree and all. So mostly because in Kerala, when we go to a medical college or somewhere, there will be the senior professors who come who are accompanied by the junior doctors or the internees or the residents or PG residents. So most of the people address the senior doctors as big doctors in Malayalam, that is Vailiya doctor, and the students or the internees as small doctors or the Cheriya doctors. So here also they do the same because the fresh postgraduates in psychology and social work are young, so they feel that these are junior doctors or just passed out or they are students of or psychiatry. So this was where this is an incident where I was sitting in the clinic and the psychiatric social worker was talking to a mother who had come on proxy for her two sons who were patients in the community mental health clinic. One was suffering from epilepsy. So epilepsy is also covered in this mental health program other than strictly speaking mental health problems. So mother was asking for tonic here, so as you can see. So she was pressing for the need. She wanted tonic somehow because she said that the son is very tired. So the social worker say that for tonic you need to see the doctor of the body who comes in the morning. So she because there is a physician who comes every day to the community palliative clinic because they offer services to the physically ill people. So she said that I don't know about the tonic. She says, is there any other issue, that any other mental health issue? I'm a mental health doctor, so you can only tell me the problem that your son is facing on account of mental health. So she again wants something to be done, either decrease the medicine or get a tonic. So the psychiatric social worker again say that if he's having problem, we cannot decrease the medicine. Let it continue as it is. So we will see after 3 weeks. So tell about the tonic to the doctor. So she was very dismissive about it, and she wanted her to leave. So she went outside, and I went and talked to her. So as she was like lying on the rails of the veranda, which is on the courtyard. So so she told me that what kind of a doctor it is. Like she's not neither decreasing the medicine or nor giving a tonic, and that her son is facing a lot of issues. So similarly, the peer support worker is also one of the major uh, major designation that we see being churned out in the clinic. And peer support worker is basically the patient who is already on medication and who is supposed to support the co-patients as they're called. So what I found is that the peer support worker, rather than listening to the patients' stories and their issues and trying to take their perspective, because of the training that the peer support worker gets from the mental health professionals, that is the psychologists or the psychiatrists, they also align with the medical professionals in order to accomplish what they want, that is the medical medicine compliance basically. So either even when they complain about side effects, the peer support workers say that because you are not taking medicine properly, that is why you are having side effects, so you need to take the medicines properly. So here also you can see the peer support worker was sitting, and he said that I was sitting in your seat before, I'm still on sodium alpha 200. So the patient, who is a 23-year-old man, he asks how did you get the disease. So he says that the peer support worker asks, how did you get it the same way. So the kind of universalization of the mental health problems or distress faced by the uh, people is somehow is what is happening. Sorry. So peer support worker again emphasizes on medicines. If you take medicine regularly without fail, medicine will be decreased, and you can sit in this seat. Means his seat, that is the peer support worker's seat. So psychologists also, I have seen how psychologists and social workers who are non-medical mental health professionals who are supposed to actually look at the other social or psychological aspects of suffering. They also align with the medical professionals and try to showcase themselves as more or less as a medical professional rather than a social or a mental health professional who is bent towards social and psychological issues. So when a community volunteer brought up an issue of family conflict, the psychologist dismissed him and said that you need to we need to have a leadership which will enable regular supply of medicine. There is no need to actually look at this. So community mental health also, what I raise here is that there was a this I have seen her over a period of time, at least I think 3 to 4 times over period of these 2 years. So she used to complain about side effects. Even she was talking to me one day, and she was asked not to talk to me as there was a strict order by the psychiatrist social worker that she should not talk to any males because she has a lot of sexual urges. So, in order to actually meant to curtail that, she was not allowed to talk to any. So she was talking about side effects, and inside a clinic also, the clinic also, she came and she was talking and she was crying. So she was talking about certain family issues also. So immediately the volunteer came and said that there is no place. This is not the place for you to cry. Tell the problem that you have to the doctor and take medicines. So nothing will happen by calling God. So she was actually repeatedly calling God and all during the cry and during the conversation. So you need to tell only the issue related to your illness. So this way, I saw that the kind of more than a community, forging a community of users and of people in the community who use services and who offer services, participating and understanding each other. There is a lot of alienation that happens because the mental health professionals and the volunteers align with each other, isolating the perspective and the voices of the patients. So what I conclude is that the capacity and because of the palliative care philosophy is very democratic, it's very rooted in social determinants of health and also looking at health as also a social issue or a political issue, also as an economic issue. But because of the coming of the NGO, there is a lot of overstating of the NGO's biomedical understandings, and this is readily accepted and implemented by the community volunteers. Their philosophy is getting lost in this collaboration. And these kind of relapse prevention, which comes from the biomedical understandings, the pro forma that they have to fill up and they have to show whether they have taken medicines, and they have to even store the used medicine strips to show the psychiatrist because it is made mandatory by the psychiatrist, and they are also afraid of the psychiatrist because they most often scold them if the patient don't take the medicines properly. The role of the state also, because we have seen how when when I have also seen the tribe when the social location of the users of the services are from the very vulnerable section, then the kind of care becomes very violated. For example, even the basic medical safety laws are violated as the social workers and psychologists prescribe medicines and they suffer from fatal side effects. And the free medicines have also become very important to actually come to take a very important space, and the silence of the victim also, because the pain palliative care center is somewhere a place where the people users of the services, then the caregivers and other volunteers, the health professionals all come together, cutting across the divisions of caste, class, or any other social divisions. But here, and they also offer lot of help to people who are suffering. So, because free kit like food kits and other emotional supports, etc., where funds are raised in the community and given to the people who are in need. So here, because of this relationship, when such violations occur, because some of them have also known when I speak, also when I told them that these are not psychiatrists or they are actually social workers and psychologists. Some of them knew already that they are not, some of them. So they said we can't actually lodge a complaint or something because some of them are getting some help due to such free medicine. So what we do now is that we go to the tertiary government medical colleges and get their prescription. At least we get the free medicine from here. So such kind of adjustments or such kind of uh, negotiations are also happening when I was there in 2017. So the what I also like what I have seen here is that there is a lot of question that are coming up about this government's participation with private funders and other NGOs, and how mental health is understood by the state, and how state also absorbs its responsibility in taking care of the basic safety laws for the most vulnerable sections when it comes to mental health. And I also argue that the state is trying to front stage mental health as a developmental agenda, and trying to show that development is done through mental health. At the same time, when the victims of such development is actually the most vulnerable sections. So how the role of the state in offering mental health itself is one of the major questions that can be raised in the field of community mental health in care. Thank you and very much, and look forward to to the discussions.
Thank you very much. We would look forward to some questions and responses now.